Basics of Medical Biochemistry. First edition, 2023. Chapter 14. Integration of Metabolism. Part 2 of 2. By Professor Dr. Muhammad Jawad. MBBS, Tao, M. Philosophy, Ph.D., Dip M.E. Head of the Biochemistry Department-Fazaia Ruth Pfau Medical College Air University-PAF Base Faisal-Karachi-Pakistan. Ex-Professor of Biochemistry, Qassim University Kingdom of Saudi Arabia. Ex-Professor, Head of the Biochemistry Department and Vice Principal. Liaquat College of Medicine and Dentistry and Fatima Jinnah Dental College, Karachi, Pakistan. 14.4 Obesity. Obesity is defined as a condition when the ideal body weight is exceeded by 20%. It is a disorder of an excess of fat in adipose tissue due to the failure of the body weight regulatory system. In obesity, fat is stored subcutaneously or as visceral fat. It is a medical condition responsible for serious comorbidity and mortality. The obesity epidemic of present-age industrialized societies is due to a sedentary lifestyle and an abundance of a wide variety of palatable foods. Obesity is one of the most prevalent diseases in the United States, alarmingly rising in children and adolescents. 17% of age group 2 to 19 are obese. The genetic tendency was found in primitive societies regarding the storage of calories owing to the high level of physical activity, as foods were available only intermittently. It is a global problem now as obese individuals are more than undernourished all over the world. Adipostat, it is a set point of the body to control adiposity, i.e., obesity of the body. It controls feeding and energy consumption. According to the adipostat theory for body weight control, alterations in body weight should always be compensated by adequate alterations in food intake and thermogenesis. Whenever the body weight exceeds this set point, there occurs a mechanism to decrease food intake and increase energy expenditure or vice versa. 14.4.1 Diagnosis of obesity. As direct assessment of body fat is difficult, so obesity is typically diagnosed by various indirect methods like the body mass index, desirable weight, relative weight, and other anthropometric measurements. 1. Body mass index, BMI. It is a calculated value that represents body weight as a function of height, scaled according to sex and age with staggering statistics that are rising annually. It is a simple calculation using a person's height and weight. The formula is BMI equals kg/m2, where kg is the weight in kilograms and m2 is the height in meters square. Table 14.4 Interpretation of BMI. BMI. Result: less than 18.5. Underweight: 18.6-24.9. Healthy, normal: 25-29.9. Overweight: 30 to 40. Obese: more than 40. Severely, morbidly, obese. 2. Desirable weight. It is the acceptable weight for a given height mentioned in Table 14.5 and 14.6 for men and women respectively. Table 14.5 Desirable weight, in pounds, for men. Table 14.6 Desirable weight, in pounds, for women. 3. Relative weight, RW. It is used to categorize obesity. It is equal to the ratio of measured body weight to desirable weight multiplied by 100. Desirable weight: RW equals times 100. Measured weight: obesity will be mild for RW of 120 to 140%, moderate for RW of 140 to 200% and severe for RW of more than 200%. 4. Anthropometric measurements. Besides calculating BMI and usual body weight measurements, there are many other anthropometric measurements are available to assess the risk of obesity. A waist circumference, WC, of greater than or equal to 40 in men and greater than or equal to 35 in women indicates a risk for obesity. Similarly, measurements of the skin fold thickness of the triceps and subscapular region are used to establish a correlation with the total body fat and percent body fat irrespective of age, sex, and race. 14.4.2 Pattern of fat deposition. the regional distribution of fat has a great impact on health risks. 1. Android, apple-shaped, obesity. It is upper body obesity, associated with fat deposition in the trunk. It has a waist-to-hip ratio, where, of greater than or equal to 1 for men and greater than or equal to 0.8 for women. It is more common in men and has a greater risk for metabolic diseases. Android fat distribution results in higher free fatty acid levels, higher glucose and insulin levels and reduced HDL levels. It also results in higher blood pressure and inflammatory markers. 2. Gynoid, pear-shaped, obesity. It is lower body obesity, associated with fat deposition in the thighs. It has a waist-to-hip ratio, where, of less than or equal to 1 for men and less than or equal to 0.8 for women. It is more common in women and has a lower risk for metabolic diseases. 3. Central obesity. It is a version of android obesity. It is due to fat deposition around the main abdominal viscera, visceral fat, and below the abdominal wall, subcutaneous fat. Central fat deposition is associated with many lipid abnormalities. Why do upper body fats have more risk? Excessive body fat in the abdominal region leads to increased circulating triglyceride levels. Because the FFA and cytokines, interleukin-6 and tumor necrosis factor alpha, released from adipocytes of the abdominal region are transported to the liver via the portal vein. In the liver, they produce insulin resistance and increase the production of TAG, which is then released as a part of VLDL. The risk for type 2 diabetes mellitus thus increased in individuals with a more central fat deposition, abdominal. On the other hand, FFA released from lower body subcutaneous regions enter the general circulation, where they are mostly burned, oxidized. Figure 14.9. Android, apple-shaped, and gynoid, pear-shaped, type of obesity. In the human body, about 80 to 90% of body fat is deposited as subcutaneous fat around the abdominal and gluteal region. The remaining 10 to 20% is in the abdominal cavity around the viscera. In obesity, the size of adipocytes increases to an average of 2 to 3 times their original dimension, hypertrophy. If overeating persists, then preadipocytes appeared and they eventually proliferate and become mature fat cells. This increase in the number of adipocytes is called hyperplasia. When weight loss occurs, the size of adipocytes is reduced without a reduction in the number of fat cells. Figure 14.10. Location of visceral and subcutaneous fat. 14.4.3. Adipose tissue as an endocrine gland. Adipose tissue can be categorized into white adipose tissue, WAT, concerned to stores energy, and brown adipose tissue, BAT, meant to generate body heat. The most significant physiological functions of WAT are the regulation of appetite, immunity, glucose/lipid metabolism, coagulation, angiogenesis, reproduction, etc. The main hormones of WAT are leptin, adiponectin, resistin, visfatin, omentin, etc. Leptin. The word leptin is derived from the Greek word leptos, meaning thin. It is a small peptide hormone having a molecular weight of 16 kDa with 167 amino acids, discovered in 1994. It is expressed by the LEP gene, also known as the OB gene. OB for obese, is located on chromosome 7q31. It is expressed mainly by adipose tissue but is also found in the skeletal muscle, gastric and mammary epithelium and the brain. Synthesis of leptin is greater in subcutaneous than in visceral adipose tissue. Females have a higher proportion of subcutaneous fat. Leptin levels are higher in females than males, partly as a result of stimulation by estrogen and inhibition by androgens. Its level is increased by food intake and resultant weight gain. In this situation, it causes body adaptations towards increasing activity and decreasing appetite to control body weight. When body weight decreases, its level also decreases and ultimately appetite is increased. In fact, the majority of obese persons are leptin resistant. That's why leptin is more efficient in the prevention of weight loss than the prevention of weight gain. Leptin level is also increased by insulin, glucocorticoids, and pro-inflammatory cytokines, while its level is decreased by fasting, cold exposure, exercise, adrenergic stimulation, growth hormone, thyroid hormone, melatonin, smoking, use of thiazolidinediones and with increasing age. Functions of leptin: its main function is to regulate appetite and energy metabolism. It also regulates the synthesis of thyroid hormones, menstrual cycle, and bone mass. Other effects of leptin include an increase in heart rate and blood pressure and activation of immune cells. It decreases the glucose-stimulated insulin release. Adiponectin: it is a protein hormone with 244 amino acids. Its gene is found on chromosome 3q27. It is involved in the regulation of blood glucose levels and fatty acid breakdown. It reduces the FFAs in blood by enhancing their oxidation in muscle. It improves diabetic symptoms by increasing insulin sensitivity. Plasma adiponectin concentrations are decreased in patients with increased body fat, obesity, but leptin level is increased. 14.4.4 Causes of obesity. 1. Overeating: the imbalance between calorie intake and energy expenditure, i.e., more intake than use favors obesity. The most common causes of obesity are overeating and lack of physical inactivity. Overeating leads to weight gain, particularly from foods rich in fat or sugar, example fast food, fried food, and sweets. 2. Frequency of eating: people who eat small meals 4 or 5 times daily have lower cholesterol levels and lower and/or more stable blood sugar levels than people who eat 2 or 3 large meals, especially diets high in simple carbohydrates. 3. Lack of exercise: lack of exercise diverts the calories to store as fat in the body, which results in gaining body weight. Sedentary people burn fewer calories than active people. 4. Genetics: a person is more prone to develop obesity if one or both parents are obese. Genetics also affect hormones involved in fat regulation. Single gene mutations, example mutations in the gene for leptin, cause hyperphagia, increased hunger, due to decreased formation of leptin. 5. Slow metabolism: people with slower metabolism tend to put on more weight than physically active persons. Muscle burns more calories by metabolism than other tissues. 6. Medications: certain medications including certain antidepressants, oral contraceptives as well as some antihypertensive medications are associated with weight gain. 7. Psychological factors: many people eat excessively in response to emotions such as boredom, sadness, stress, or anger. 8. Diseases causing secondary obesity: many medical conditions such as hypothyroidism, insulin resistance, polycystic ovarian syndrome, PCOS, and Cushing's syndrome are contributors to obesity. Certain disorders of the hypothalamus such as Froelich syndrome, Lawrence-Moon syndrome, and Prader-Willi syndrome are also associated with obesity. 14.4.5 The complications of obesity: it is the justified intention to have a well-built body but not to be obese, because obesity is not just a cosmetic problem, it is a risk for many health problems, such as cardiovascular disease, diabetes, high blood pressure and even some cancers. Table 14.7 Effects of hormones, neuropeptides, and drugs on appetite. Increase appetite. Decrease appetite. Neurotransmitters. Norepinephrine. Growth hormone releasing hormone. Serotonin. Dopamine. Neuropeptides and hormones. Opioids. Ghrelin. Gastric inhibitory peptide. Neuropeptide Y. Ghrelin. Orexin A. Melanin concentrating hormone. Agudirelated protein. Cholecystokinin. Enterostatin. Melanocyte stimulating hormone, MSH. Tumor necrosis factor. Glucagon-like peptide 1, GLP-1. Corticotropin releasing hormone, CRH. Propiomyelanocortin, POMC. Melanocortin. Peptide YY. Amylin. Adipsin. Leptin. Drugs. Corticosteroids. Progestins. Few antidepressants. Few tranquilizers. Amphetamines. Sibutramine. 1. Cardiovascular disorders. obese individuals are at a greater risk of developing cardiovascular disorders like hypertension, stroke, and coronary artery disease. Adiponectin, which is a cardioprotective agent, is decreased obesity. Arteries in the heart, brain, kidneys, and legs harden faster in obesity. This can cause a heart attack, stroke, kidney failure, or become a leading cause of amputation of part of the extremities. As BMI increases, there is an increased risk for heart disease. Obesity and hypertension affect cardiac function drastically, leading to the thickening of the ventricular wall and larger heart volume to produce a condition of congestive cardiac failure. Varicose veins are also common in obese persons. 2. Dyslipidemia. There is a positive correlation between BMI and triacylglycerol, TAG, levels. Excessive body fat in the abdominal region leads to increased circulating TAG levels. Central fat deposition is more concerned with lipid abnormalities. 3. Respiratory problems. Obesity is associated with obstructive sleep apnea. It is characterized by loud snoring, upset fragmented sleep, and excessive daytime drowsiness. Obstructive sleep apnea is caused by repetitive upper airway obstruction during sleep as a result of the narrowing of the respiratory passages. Patients having this disorder are mostly overweight with associated peripharyngeal infiltration of fat and or increased size of the soft palate and tongue. Tolerance to physical exercise is decreased, and hypoventilation causes increased formation of erythropoietin. Increased formation of RBCs and raised hematocrit result in thromboembolic phenomena. 4. Bone and joint problems. The incidence of osteoarthritis is quite common among overweight individuals. Osteoarthritis that develops in the weight-bearing joints, knees and hip, is probably directly related to the trauma associated with the degree of excess body weight. Backache is also very common in obese. 5. Dehydration. Obese individuals lose more water due to excessive sweating, as an excess of subcutaneous fat makes it difficult to lose heat by radiation and convection. Heat production is more in obese than in thin individuals. 6. Diabetes mellitus. There is a strong association between obesity and type 2 diabetes mellitus in both sexes and all ethnic groups. The risk for type 2 diabetes mellitus increases with the degree and duration of being overweight, particularly with central obesity in individuals. About 80% patients with type 2 diabetes mellitus are found obese at the time of diagnosis. 7. Other endocrine disorders. Obesity is associated with many endocrine changes like increased cortisol production, decreased growth hormone production, decreased sex hormone binding globulin in women, decreased progesterone levels in women, and decreased testosterone levels in men. 8. Cancer. Being overweight and obese are associated with an increased risk for many cancers. Obesity and physical inactivity may account for 25 to 30% of several major cancers. Fatty males mostly suffered from cancer of the colon, rectum, esophagus, pancreas, and liver. Fatty females commonly have cancer of the gallbladder, bile duct, breast, postmenopausal, endometrium, cervix and ovaries. 9. Reproductive changes. Irregular menses, frequent anovulatory cycle, PCOS, and infertility are common in obese women. Rates of infertility may be reduced by decreasing obesity. In males, hypogonadism occurs through the conversion of testosterone into estrogen by excessively released aromatase from adipose tissue. 10. Diseases of gallbladder. The incidence of gallbladder stones is common in obese females. Other problems like hiatus hernia and associated gastroesophageal reflux disease, GERD, are also prevalent among obese persons. 11. Psychological disorders. Obesity is associated with impaired quality of life. Obese are prone to get mental depression easily due to low self-image. They have poor confidence levels due to unkind remarks and jokes. 12. Low immunity. Obese individuals have less resistance to infection. They are frequently suffered from various respiratory infections and fungal infections of the skin. 13. Shorter life expectancy. Due to the large number of comorbidities, obese individuals have comparatively shorter life expectancy than non-obese. The research found that moderate obesity reduces life expectancy by about 3 years, and that severe obesity can shorten a person's life by 10 years. 4.4.6 Prevention and treatment of obesity. following objectives are recommended by health-caring authorities to prevent obesity. Reduce risk factors of chronic disease. Increase awareness and understanding. Implement global, regional, and national policies and action plans. Monitor science and promote research. A healthy weight is the main goal for obesity treatment, and it can be achieved by making a good treatment plan with a team comprises of a doctor, nutritionist, dietitian, obesity specialist, and nurse. 1. Diet control. It is one of the most effective strategies to prevent and control obesity. A healthy diet with proteins, 15 to 20% of calories, carbohydrates, 55% of calories, and fat, 30% of calories is recommended. The diet should provide adequate nutrients and support dietary compliance. Intake of bulkier foods such as fruits, vegetables, and salads with low calories is beneficial. The use of refined sugar should be avoided, however artificial sweeteners can be used. Avoid saturated and trans fats. 2. Physical activity. A minimum amount of physical exercise is essential to keep the appetite center at a regular level. Exercise of 150 to 250 minutes of moderate intensity activity such as fast walking and swimming every week is helpful to reduce obesity. 3. Lifestyle modification. Behavioral therapy can help in many ways to shift an obese individual from a sedentary lifestyle to an active one. Patients are encouraged to avoid the use of automobiles for short distance movements all the time, rather use of the bicycle is encouraged. Avoidance of remote for home appliances, not eating before watching television programs or in the car, and use of small plates are helpful techniques. Self-monitoring of body weight, use of a pedometer, and how much time is given to physical activity should be kept in view. 4. Medications. Obesity is treated by comparatively a new field of medicine called bariatrics. Various drugs are in use to control obesity. Orlistat is a lipase inhibitor that reduces fat absorption. It inhibits digestion of dietary triglycerides, decreases absorption of cholesterol and lipid-soluble vitamins, and brings about 30% reduction in energy intake. This drug should be added with multivitamins because of the reduction in the absorption of fat-soluble vitamins. Appetite suppressants such as noradrenergic 4, phentermine, diethylpropion, noradrenergic 3, bensphetamine, phendimetrazine, serotonergic, fenfluramine, dexfenfluramine, mixed noradrenergic and serotonergic, sibutramine, are also used to control obesity. Thyroxine is recommended to treat obesity due to hypothyroidism. 5. Surgery. Bariatric surgery is used to remove fat from the body. Various minimally invasive techniques are available in this field of laparoscopic surgery, like gastroplasty, gastric bypass, sleeve gastrectomy, adjustable gastric band, and biliopancreatic diversion with duodenal switch. 6. Primitive responsibility. It is a satisfactory fact that obesity is preventable. It is usually caused by excessive eating than need. The following are the recommendations of the WHO for the prevention of obesity. Have a balance of energy and a healthy weight. Limit how much fat we eat. Increase fruits and vegetables. Limit sugars and soft drinks. Increase exercise to at least 30 to 60 minutes per day on most days. Summary. Different metabolic pathways in the body are interrelated with one another. This is called the integration of metabolism. Liver and adipose tissue function as fuel storage tissues and reservoirs. The liver can use all fuels except ketone bodies. The brain is simply a fuel consumer. Muscle is both source and a consumer, leaning heavily towards consumption. The kidney is a significant source of glucose via gluconeogenesis during starvation. Fed or anabolic state occurs immediately after a meal. Glucose is rapidly transported into the liver during a well-fed state. Amino acids are used in protein synthesis in a well-fed state. Fatty acids synthesis, lipogenesis, occurs in a well-fed state. Increased insulin promotes glucose uptake by adipose tissue during a well-fed state. Increased glycolysis and glucose oxidation as well as glycogenesis occur in skeletal muscle during a well-fed state. The brain uses about 120 g of glucose per day. In 70 kg men, fat as tag stores is the largest and sufficient to meet energy needs for about 3 months without any food intake. Starvation is a catabolic state in which glycogen, tag, and proteins are degraded. In starvation or fasting, there is a decline in blood glucose and amino acids resulting in a decrease in the insulin/glucagon ratio. During starvation, the first priority is to provide sufficient glucose to the brain and other tissues that are dependent on it. Within 2 to 4 hours of meal intake, absorption of nutrients from the intestine is completed. Insulin levels drop and glucagon levels rise in the post-absorptive early stage of starvation. Most acetyl-CoA is converted to ketone bodies by ketogenesis in the liver during starvation. The primary role of the liver in fasting is to maintain glucose supply to glucose-requiring tissues. The importance of gluconeogenesis is to supply glucose to glucose-dependent tissues, CNS and RBCs. After 2 to 3 weeks of fasting, the brain adapts to the use of ketone bodies. A decrease in insulin/glucagon ratio in starvation reduces the glucose entry into muscle and adipose tissue. Normal fasting blood glucose level is 70-100 mg/dl. It rises after a meal but returns to a normal fasting level by the time of the next meal. Obesity is a disorder of an excess of fat in adipose tissue due to the failure of the body weight regulatory system. A BMI value of 30 to 40 indicates obesity. Android, apple-shaped, obesity is upper body obesity, associated with fat deposition in the trunk. Gynoid, pear-shaped, obesity is lower body obesity, associated with fat deposition in the thighs. The main hormones of the adipose tissue are leptin and adiponectin. The main function of leptin is to regulate appetite and energy metabolism. The level of leptin increases when body weight increases. This raised level of leptin is concerned to reduce appetite to control obesity. The most common causes of obesity are overeating and lack of physical inactivity. Obesity is a risk for many health problems, such as cardiovascular disease, diabetes, high blood pressure and even some cancers. References. Exercise questions. MCQ 1. Which of the following reactions takes place during the digestion of triacylglycerol to fatty acids and glycerol? Dehydration, hydration, hydrolysis, oxidation, reduction. MCQ 2. The major metabolic product produced under normal circumstances by erythrocytes and muscle cells during intense exercise is recycled through the liver in the Cori cycle. Which of the following metabolites is produced in this cycle? Glycerol, lactate, oxalostate, phosphenolpyruvate, pyruvate. MCQ 3. Which of the following metabolic activities is decreased following exposure to physiologic concentrations of insulin? Glucose oxidation, gluconeogenesis, lipogenesis, formation of ADP, glycogenesis. MCQ 4. 2 weeks after an episode of the flu, an 8-year-old boy with IDDM is brought to the emergency room in a coma. His breathing was rapid and deep and had a fruity odor. His blood glucose was 620 mg/dl. The physician administered insulin. Which of the following is the rapid effect of administered insulin in this patient? Fat breakdown, gluconeogenesis in the liver, glucose transport in muscle, glycogenolysis in the liver, ketone utilization in the brain. MCQ 5. A healthy 38-year-old man showed a peak serum glucose concentration of 225 mg/dl within 30 minutes of participating in a glucose tolerance test after the consumption of 70 g of glucose. 2 hours after ingestion, the measurement of his serum glucose concentration reduced to 92 mg/dl. The observed decrease is due to the normal responses of tissues to insulin mainly and also partly by the activity of which of the following enzymes? Aldolase, galactokinase, glucokinase, phosphenolpyruvate carboxykinase, phosphofructokinase 1. End of Part 2 of 2 of Chapter 14. Thank you.